My slides, yeah. I'm going to start with the question as well. We have a 81-year-old lady with an atrial fibrillation, non-valvular. She has a CKD with a creatinine clearance which is low. She has hypertension and diabetes. In such a situation, what would you do? Would you not anticoagulate her? She's 81 years old and CKD. Would you give her warfarin? Would you give her dabigatran? Would you give her apixaban? Yeah. Please do.
Please vote. Please vote. Time starts now. No. Option. Please vote. Option. Let us see.
It's equally divided. So let's look what the data is. Can I go to my next slide, please? Yeah. So you decide upon whether you should anticoagulate a patient or not simply on the basis of age. You need to look at the JADS-VAS score, and I'm not going to go into details of JADS-VAS score, but if the JADS-VAS score is 2 or more, then the patient has a very high incidence of stroke, and therefore you need to anticoagulate this. This lady with the diabetes, hypertension, and age had a vascular score of 5, which gives her a stroke risk of 7.2%. Therefore, she needs to be anticoagulated. So the answer, do not anticoagulate, is not correct. Let us look at the second aspect. Should you use warfarin or should you use NOACs? So that's the important question. As we saw in the earlier questions, most of you said that you continue to use warfarin. One of the reasons would be that it is cheaper. However, that is no longer true because we have generic dabigatran available with us today. The cost issue is also not there. So the only reason why you continue to use warfarin is probably you're not adequately experienced with NOACs and one needs to, and the best way to get experience is to first get knowledge, and that's the aim of today's talk. And if you look at the NOACs versus warfarin, and if you look at the 3 big trials, the rivaroxaban, apixaban, and dabigatran, you can see almost each one of them that it favors NOACs. And if you look at ischemic stroke, if you look at intracranial hemorrhage, all are in favor of NOACs. And one of the biggest advantage that NOACs has in terms of warfarin is that it reduces intracerebral hemorrhage. Now the biggest worry when you start warfarin in patients is bleeding. And bleeding may be anywhere, but the most important is either fatal bleeding because of excessive bleeding anywhere or intracerebral hemorrhage, which can be catastrophic. And the one thing that all NOACs do is that it reduces the incidence of intracerebral and fatal hemorrhage as compared to warfarin. That's a very good reason for using warfarin. It's also more important to use warfarin in Indian patients because we are more prone to bleeding. We have got a genetic pleomorphism which makes INR control very difficult. We've got a lot of drug interactions, herbal medicines. Physicians prefer a lower range of INR. A lower range of INR will result in not sufficient prevention of strokes, and therefore Asian patients clearly do even more benefit. And many of these studies actually had Indian patients in them, and the Indian patients did extremely well on NOACs. So I think Indian patients, particularly Asian patients, need to be on NOACs. Then of course the question that we all worry about is that patient was 81 years old. Now what is the data on elderly patients? Now if you look at all the groups, the dabigatran, rivaroxaban, apixaban, if you look at the efficacy in the older age group, you see that the stroke incidence is reduced, but most important, major bleeding and particularly intracranial bleeding will be reduced. So whatever the age of the patient, if you need to anticoagulate them, the patient is much better off on a NOAC as compared to warfarin. Do we need to adjust the dose at the age? If you look at the age, the patients actually between 75 to 80, you don't really need to reduce the dose. So even for an 80-year-old person, you don't need to reduce the dose. But if the patients above 80, this is a very common phenomenon in the Western world. Above 80, atrial fibrillation, there are thousands of patients. In this particular situation, you would reduce the dose of dabigatran to 110. You don't need to change the dose of rivaroxaban, and apixaban you reduce the dose to 2.5, particularly if there is a small body weight or if there is a creatinine clearance which is high. Now renal issue is a very important issue because you choose NOACs depending on renal function. For example, if you take the renal function and rivaroxaban, then if you have a creatinine clearance of less than 50, then you need to reduce the dose. If your creatinine clearance is more than 50, you don't need to reduce the dose. And for most NOACs, if the creatinine clearance is less than 50, you do not use NOACs. So as per recent guidelines, if your patient is on severe renal dysfunction, one should not use NOACs in these patients. If you look at the renal effect on apixaban, you can see out here that when the creatinine clearance is less than 30, you need to reduce the dose down to 2.5. When the creatinine clearance is more than 30, then you need to look at age, weight, etc., and then reduce the dose as required. And if you look at dabigatran, it's the most complicated, because dabigatran is predominantly excreted through the kidneys. So therefore, any patient with creatinine clearance which is abnormal will have problems with dabigatran. So I have a very simple suggestion to all of you who are planning to use NOACs or already using NOACs. If there's any issue with renal dysfunction, if the creatinine is high, creatinine clearance is low, simply don't use dabigatran. You've got two other drugs which you can use. In case you have to use dabigatran because it's generic and cheap, then you need to carefully look at the patient's age, you need to look at the patient's creatinine clearance, and definitely reduce the dose down. We do have 75 milligrams available with us in dabigatran, and you could use 75 milligrams. But please do remember, if possible, to avoid dabigatran in patients with renal function. Now, the guidelines suggest that when you have hemodialysis, that we do not use NOACs. But this slide was correct from maybe 2 days ago. But about 3 or 4 days ago, there's a big paper out looking at the real-world life data on apixaban in hemodialyzed patients. And in fact, I was told yesterday at one of the meetings I was that 4 days ago, FDA has approved the use of apixaban in hemodialysis patients. So as of this, I would say just a couple of days now, if you have to choose a patient on hemodialysis and you have to choose the NOACs, then apixaban can be used. And they suggested that if you use a full dose of apixaban, 5 milligrams twice a day in hemodialysis patients, the bleeding is less than warfarin and the stroke incidence is much less. This is the very, very recent data that has come out. It's also important to remember that when you give patients NOACs, that as time goes by, a year, 2 years later, because they're elderly patients, the creatinine clearance often falls with time. So you need to monitor them closely. So would you like to answer this question again now? The same question which I asked you. Would in this patient use no anticoagulation, warfarin, dabigatran 150 twice a day, or apixaban 2.5 twice a day? Could you answer that again, please? Can you answer that? Very good. So I think most of you understood that probably the safest thing to do in a situation with a renal dysfunction in a very elderly person is to use apixaban in small doses. I told you that if you have renal function, do not use 150 milligrams of dabigatran. So some of you suggested 150 milligrams. So I suggest, some of you suggested 150 milligrams. You should not use 150 milligrams. Warfarin, again, I see no reason to use it at all. And no anticoagulation, I also explained. So I think in a situation like that, the best thing would be to use 2.5 milligrams. Now, one thing that we see very commonly amongst physicians and cardiologists is that we tend to use lesser doses of all drugs. And we've done that as well with NOACs. Many of us use 2.5 milligrams of apixaban in the hope that we will get less bleeding. The question is, yes, of course you will get less bleeding. But look what happens out here. You not only get less bleeding, but you get less benefit in terms of stroke, etc. also. So it's very important that when you are using NOACs, to use the appropriate dosage. So yes, if the patient is above 80, you need to reduce the dose. If the patient's got renal dysfunction, you need to reduce the dose. But do not just reduce the dose for the sake of reducing because you are anxious about the bleeding. Because if you get no bleeding, you probably want no stroke prevention as well. So appropriate use of drugs in the correct dose is very important. Question number 2. Here is a 64-year-old male with rivaroxaban 20 milligrams. He's planning to go for spinal surgery. It's a major spinal surgery. This is a common problem. Patient may be on warfarin, patient may be on NOACs. And the patient is going for a spinal surgery. His creatinine clearance is normal above 80 milligrams. What would you do? There's no need to stop NOACs. Just let the patient go for surgery. Should you stop rivaroxaban on the day of the surgery and go ahead? Should you stop it 5 days before? Should you stop it 2 days before? Correct answer is what you given, that's 2 days before. Certainly NOACs need to be stopped, because if you have a patient who's anticoagulated, and as I mentioned to you, this is planned surgery. If you have emergency surgery, you can look into how to deal with that patient. But if you have planned surgery, it makes no sense to operate the patient on anticoagulation. There will be unnecessary bleeding, and therefore, therefore this patient is going to have problems. Now this is a chart which sort of explains to you how to adjust the dose of apixaban, dabigatran and rivaroxaban in patients going for elective procedures. Now there are two things that you need to look at. One is you need to look at whether it's a low risk or a high risk procedure, and you need to look at creatinine clearance. Now if you've got a drug like dabigatran, which is predominantly excreted in the renal, then if you've got a creatinine clearance of even 30 to 50 mils, you might have to wait for 48 hours to 96 hours. So clearly, if your patient is on dabigatran, is going for planned surgery, and you've got mild creatinine elevation, you need to wait as high as 96 hours. On the other hand, if the patient is taking rivaroxaban, which is predominantly not excreted by the kidneys, and his creatinine clearance is normal, like in our patients, 2 days is usually enough. So before you decide on how long to stop a NOAC in a patient going for planned surgery, you must first see whether the surgery is high risk, whether surgery is high risk or low risk, and what is the creatinine clearance, and what type of drug which is on. So it's clearly not very easy when you decide to stop drugs. You have to see all these parameters, and there is no fixed duration and which to stop the drugs. Of course, if you simply stop all of them 5 days before, and surgeons usually say stop the drugs 5 days before. That's not correct either, because then during the stopping, you might land into problems. Now, many times these patients are old, they fall down and they injure themselves and they bleed, or they spontaneously bleed, gastric bleeding or some other bleeding. How do you manage these patients who bleed? This is a real-world study looking at the major bleeding with rivaroxaban and how do you treat these patients. Actually, they found that in the majority of patients, you really don't need to do much. And the reason is very simple. Most of the NOACs are short-acting, and their effect lasts for a short time. As you know, within 24 hours, drug is almost gone in most of the patients till the creatinine is normal. And within 12 hours, the effect is considerably reduced. So unlike warfarin, where the effect lasts for days together, stopping the NOAC itself is probably the best treatment in these patients. So what you need to do in the majority of patients is simply stop, don't do anything else. Of course, you can give transfusion if the hemoglobin drops too much. You can do all sorts of other things like PCP, etc. But I must mention that many of these things are not even available at most hospitals, and this was used in just about 0.5% of the patients. So I think bleeding is not such a big issue in these patients, and but must not get scared of using NOACs in patients who start bleeding. Now, as we know, we have two antidotes which are available. This is for dabigatran, and this one is for apixaban and rivaroxaban. As you know, Praxpine is already available with us. It's available in many centers in Bombay. It costs about 70,000 rupees for the dose for antidote, and it's extremely effective. The antidote, the adenexate alpha antidote, will be available in India probably at the end of next year, and that will be an antidote for apixaban and rivaroxaban as well. So we do have antidotes as well. And the one which is available today for the dabigatran basically comes as 2.5 grams, and you have to give them a total of 5 grams, 2 vials of 2.5 milligrams. And the important aspect is that the effect is almost instantaneous. So you have a patient who comes maybe with an accident, or a patient who comes with bleeding and is requiring emergency surgery. You give the antidote, and within 10 minutes the effect of dabigatran is gone. Now, of course, this antidote only works for dabigatran. It does not work for apixaban or rivaroxaban. But clearly we have a very, very powerful antidote which we don't have for warfarin. Please remember that when you give vitamin K for warfarin, it doesn't act immediately. It takes a long time. Warfarin effect persists. So we always think that we've got an antidote for warfarin, but we don't have an antidote for NOACs. But on the contrary, the antidote, at least for dabigatran, and next year for the other two drugs also, is available and extremely useful. And this has also been approved by FDA and should be available to us next year. Question number 3. This is a 74-year-old male patient. The patient is on dabigatran, 150 milligrams, and he still gets a stroke. And you must remember that you reduce the stroke with NOACs, but you don't completely stop it. So you do get some patients, and we have them also, who are on drugs and who still have stroke. What would you do in such a situation? Patient's on dabigatran, he gets an ischemic stroke. Should you continue dabigatran, don't do anything more? Should you give an antidote and stop the effect of dabigatran? Should you stop dabigatran immediately and give thrombolysis because that's the current treatment for ischemic stroke? Or should you give stop dabigatran and do some mechanical extraction, which is also done in most of the centers? Please answer. The one thing you must remember is never to thrombolize the patient. So if a patient is on NOACs, and if you stop NOAC and you thrombolize the patient, which is what I think you must have said, it's very harmful. It's going to produce significant cerebral hemorrhage. So in a patient who's on NOACs, NOAC effect hasn't worn off, you cannot thrombolize this patient. So the best answer would be mechanical extraction if it's possible. If it's not possible, then you simply stop the drug and you wait and watch. That's all that you can do. But again, important point to make for today is if the patient is on NOACs and has recently received his dose of NOACs, do not give thrombolysis to the patient. Either if it's a myocardial infarction or it's a stroke, thrombolysis and NOACs should not be used together. Now in the ischemic stroke, for example, if the intake of the NOAC has been within the last 48 hours, it's better to avoid thrombolytic therapy. You can check PTT and PT, but again, PTT and PTT are not guidelines to measure the level, but in case PT or PTT is high, it means the drug effect is still present, and definitely you should not give thrombolysis. And of course, the best thing is to do mechanical removal of the clot. One of the other things which is a very recent thing that people have done is that if the patient is on dabigatran, just bring down and the left. Hello? Yeah. Can you hear? Yeah. So in case the patient is on dabigatran and the patient has an ischemic stroke, we said you cannot give thrombolysis. But what they've done now, and this is particularly a series which is coming out from Germany, is they're giving the antidote. And in fact, a couple of these cases have been reported from India as well. So you give the antidote to the dabigatran. As I mentioned to you, within 10 minutes, the effect of dabigatran is gone. And then you can thrombolize the patient. So this is the latest in the treatment of ischemic strokes in patients who are on NOACs, particularly dabigatran. So this has been tried and is going to get more and more popular. So you give the dabigatran antidote, the effect of dabigatran is gone, and then you can thrombolize these patients. Now, once a patient has had an ischemic stroke, when can you restart the NOACs? Because you need to restart, because the fact that he's had a stroke, it suggests that he's more likely to have another stroke as well. And the usual criteria is 1, 3, 6 days, depending on whether it's a TIA, mild stroke, moderate stroke, or severe stroke. You need to be very careful in moderate and severe strokes before you start NOACs again, because many times, as you know, they get hemorrhagic transformation. So you've got to take a very good help from a neurologist, and only when there is no doubt that the transformation into hemorrhage is not going to take place, that you should start on NOACs. So don't be too anxious to restart NOACs unless it's just a TIA with no real intracranial damage. Now what happens if you get a hemorrhagic stroke? Well, that's also possible. We clearly know that NOACs will reduce the chance of hemorrhagic stroke compared to warfarin, but you still do unfortunately get hemorrhagic strokes. And what can you do? Well, you can discontinue NOACs, which obviously you will do, there is no doubt about it. You can give BCCM, fresh frozen plasma. More important, these days we give the antidote. So if your patient is on dabigatran and gets a cerebral hemorrhage, the best treatment today is to give the antidote, because you will immediately stop the effect of dabigatran. But you must clearly remember that in all these patients, like warfarin bleed, the prognosis is very poor. There have actually been studies again in Germany where they have used patients with cerebral hemorrhage and they've given dabigatran antidote and found that there's a considerable benefit in these patients. So we do have some form of therapy in dabigatran patients who are getting cerebral hemorrhage. So to answer this question, we won't go through it, but clearly the answer would be not to continue dabigatran, but to stop dabigatran. It would be stop dabigatran and give immediate thrombolysis, not advisable. The correct answer would be to do mechanical extraction. Now this question you can look into it, because now we have a patient who's got atrial fibrillation. We know that ischemic heart disease and atrial fibrillation is very commonly associated. So you have a 54-year-old man now. He's on apixaban, proper dose, 5 milligrams twice a day, and he presents to you with chest pain and an acute myocardial infarction. his kidney function is not a problem. So what do you do? You've got a patient who's on a NOAC and who's got an acute myocardial infarction now. How do you treat this patient? These are very complex patients and you need to treat them very carefully. What would you do? Would you continue apixaban? Sorry, I keep pressing wrong. Continue apixaban and give aspirin? Would you stop the apixaban and give aspirin and clopidogrel and do PCI? Would you stop apixaban and give thrombolysis? Would you stop apixaban and give aspirin and ticagrelor? So basically, would you continue or stop apixaban? Number one. And would you use clopidogrel or would you use ticagrelor or would you thrombolize the patient? So you got all the possible answers. So let me get back now. Can I go back? Okay. So stopping dabigatran and doing nothing is not a solution. Patient got an infarction.
Question number 4.
Sorry.
Question 4.
Question. So what would you do? Continue apixaban and give aspirin and do PCI? Usually you stop apixaban. You don't usually continue the apixaban and do PCI at the same time. Number two, should you stop apixaban and give aspirin, clopidogrel, do PCI? This is the correct answer. But what you do is you stop the NOACs and you treat the patient like you would any other plasty. You give aspirin, clopidogrel and do angioplasty. You would avoid ticagrelor because you don't have enough data with NOACs and newer antiplatelet agents, so you avoid the use of ticagrelor. And again, like in a stroke patient, you would not give apixaban and thrombolysis. So the answer is that you stop the apixaban, you give aspirin, you give clopidogrel, and you go ahead with your angioplasty. Now in patients who got both stroke and myocardial infarction, those who got atrial fibrillation and who had a recent stent implantation, again these are very common patients. We see very frequently a patient who's had an angioplasty, who's got a stent, who's got atrial fibrillation. How do you deal with this patient? Because now we have got to worry about stent thrombosis, we got to worry about stroke, and then if we combine platelets and oral anticoagulants, we have to worry about bleeding as well. So this really is an important aspect that we need to look at. So here is a patient who comes with NOAC and presents with an acute myocardial infarction. As I mentioned, if it's acute myocardial infarction, then you do PCI, you don't give them thrombolytic therapy. If it's a non-ST aggravated myocardial infarction, you can treat them medically and then after 24 hours take them for angiography. You use aspirin and clopidogrel, you avoid prasugrel and ticagrelor. You use a radial approach rather than femoral because that's associated with less bleeding. You still have to give heparin to these patients even if they're on NOACs. And of course, if they're on multivessel disease and they are in atrial fibrillation, from a long-term perspective, it may be better to do bypass surgery because you can continue NOACs after bypass surgery and it's more complicated to use aspirin and clopidogrel. Now, what do you do with these patients in which you finished your angioplasty? You've done an angioplasty to these patients and they've got atrial fibrillation as well. So you've got antiplatelet therapy going on aspirin, clopidogrel, and you've got a patient already on atrial fibrillation, so you need to start a NOAC in these patients. So what do you do in this sort of patients? Do you continue apixaban and aspirin? Do you stop the apixaban and give only aspirin and clopidogrel? Or would you give aspirin and ticagrelor and without apixaban? Or would you continue apixaban and continue aspirin and clopidogrel? So would you give all the three drugs together? Give just two drugs? Would you use ticagrelor or clopidogrel? Again, it's not surprising that I get these answers because these are very difficult questions to answer, and there's a lot of work being going on into how to manage these patients. And next slide. And the best I can show you is this slide and the data from the 216 guidelines as to how to manage patients who are atrial fibrillation and angioplasty both. And clearly what you do in this situation is that you continue triple anti-therapy for a period of 1 month if the patient is a stable patient. If the patient is an unstable patient like a myocardial infarction, you continue for 3 months. So you give both NOACs, aspirin and clopidogrel for 1 month or 6 months, and after that you reduce them down only to NOACs with only aspirin or clopidogrel, and after 1 year you you can stop both aspirin and clopidogrel. So the important thing is that yes, you give them all the three drugs for a short period of time, 1 to 6 months. After that, you stop the aspirin or the clopidogrel, give them only 2 drugs, and then after 1 year, you stop both aspirin and clopidogrel, and you continue with NOACs only. So this is the present recommendation that we follow. Yes, you will get increased bleeding when you give all the 3 drugs together, but you can't help it. The patient got ACS, patient got a stent, and the patient's got a stroke as well. So you need to give all the 3 medicines. But it's important to remember that after 1 year, you can actually, even in a patient who has an angioplasty and a stent, you can stop the aspirin and you can stop the clopidogrel, and NOACs alone will be sufficient to take care of that patient. Now, there are many trials with PCI in patients with AF, and I show you a couple of them. There is a trial called the rivaroxaban called the Pioneer trial, and what they have done is they have used rivaroxaban 15 milligrams along with a single antiplatelet, which is usually clopidogrel, in patients undergoing angioplasty, and they have compared that with warfarin or with small dose of rivaroxaban, and they find that the best combination to use in these patients is 15 milligrams of rivaroxaban along with clopidogrel. So if you use this, which is the pink group, then you get the maximum benefit in terms of cardiovascular events and you get minimal bleeding. If you use 2.5 milligrams of rivaroxaban, it unfortunately does not prevent strokes. So if you have a patient who's got a stroke and a patient who's got an angioplasty, and if you have to use a NOAC, then one of the best situations is to use 15 milligrams of rivaroxaban along with a single antiplatelet drug. And there's one trial with dabigatran as well, and what they have done is combine dabigatran 150 along with clopidogrel, or dabigatran 110 along with clopidogrel, or a usual combination of warfarin, and they found the same thing again, that when you use dabigatran, either 110 or 150 milligrams, the incidence of bleeding was much less and the benefits were equal. So clearly, if you want to combine both the drugs together, you can use 15 milligrams of rivaroxaban, or you can continue to use 110 milligrams twice a day of dabigatran along with a single antiplatelet like clopidogrel. Is there any situation where you stop NOACs and use warfarin? Well, there are 3 situations. One is a prosthetic metallic valve, and the reason for that is that NOACs are not strong enough to prevent contact thrombosis, which is a metallic valve produces a lot of contact thrombosis, and NOACs do not prevent that. So any patient with a metallic valve, you cannot use NOACs. If you got a bioprosthetic valve, which is what is mostly used today, the pig valve or tissue valve, then in that case you can use NOACs. So you can use NOACs with tissue valves, but you cannot use NOACs with metallic valves. If a patient has got severe mitral stenosis and has got atrial fibrillation, then NOACs, we don't have data actually, because they don't see severe mitral stenosis in the West. So nobody has looked at it. Indians haven't looked at it either, but that's one other contraindication. I mentioned to you hemodialysis here, but I said as recently, very, very recently, just a few days ago, it is possible now to use apixaban in these patients. Mustn't forget drug interactions with NOACs, because we often talk of drug interactions with warfarin, and we don't realize that NOACs have drug interaction, but there are a lot of drug interactions, and you can see particularly with amiodarone, which we commonly use in atrial fibrillation, with digoxin, with diltiazem, with verapamil. So these are the drugs: verapamil, diltiazem, dronadrone, which we don't use now, of course, amiodarone, and these can produce interactions with dabigatran, apixaban, and rivaroxaban, and in fact, it raises the level of these drugs. So please remember that it's not just warfarin which has got drug-drug interaction, but also NOACs have drug interaction, and do not forget that we seem to think that they don't have any interaction. For those who want to have a review of the dabigatran, of the whole NOAC, we have published this recently in March 2018 in JAPI. So if you read this paper, you get a complete overview of NOACs in the present scenario. Now, I'd like to end with just one last thing, that now NOACs have suddenly gone beyond the scope of atrial fibrillation, and NOACs are now being used for vascular prevention. And this is the latest study, which is called the COMPASS trial, which used NOACs in patients with ordinary CAD and PAD. That means they had no atrial fibrillation, they had no stents, no angioplasty, just stable coronary or peripheral vascular disease. and they found that these patients had significant reduction in terms of their vascular events. So simply, normally we just give aspirin to these patients, but if you add rivaroxaban small dose to aspirin, you get significant benefits in terms of vascular events. So clearly now we have a new therapy for simple treatment of vascular disease, and the benefit of these patients outweighs the hemorrhagic problem. So what they call as the net clinical benefit is significantly in the favor of using rivaroxaban. So just to summarize, I think the whole spectrum of NOACs in atrial fibrillation with ischemic heart disease, and now the new concept of using NOACs in vascular prevention. Thank you very much.
Thank you, Dr. Dalal. Friends, you heard the authorities speaking on the NOACs, and I am sure questions will be raised. Can you please pass on the questions?
Direct oral anticoagulants. So they are also called direct oral anticoagulants. I think the future looks like these are the drugs. Slowly the warfarin is going to, the indications is going to slowly coming down. And the first question is Dr. Divesh Visaria. Patient already on dual antiplatelet like aspirin with clopidogrel, public ticagrelor, post-MI. Which anticoagulants will you use? Novac or warfarin for TVT?
I see no reason to use warfarin at all in any of these patients, because if you use dual antiplatelets and warfarin, that's a maximum chance of getting cerebral hemorrhage and bleeding. So there's no indication for warfarin. You can use any of the NOACs in these patients. I would suggest that you do not combine NOACs with ticagrelor at the moment because the data is limited. Those people have used it. I would suggest that you use if the angioplasty is recent, then you will have to use aspirin, clopidogrel, and any of the NOACs. Preferably you could use a smaller dose of NOACs in the initial period. But after 6 months, you stop either the aspirin or clopidogrel, and you simply use the NOAC with a single antiplatelet therapy, and after 1 year, use only NOACs, any NOACs, without any antiplatelet therapy, even if the patient got a stent.
And again he's asking the anticoagulants already patient on. If you want to start an antiplatelet, whether you start a single or dual for IHD, and which one is that?
Usually, if you want to stop dual antiplatelets, yes, I would stop a single antiplatelet. Most people will stop clopidogrel and continue aspirin. However, there's some evidence to suggest there's a voice trial which looked at aspirin and clopidogrel versus warfarin, and they found that it is better to stop aspirin, much against what we actually do. There's suggestion that it is better to continue anticoagulation with clopidogrel, because I think what is coming out is that we think aspirin is a very safe drug, but aspirin is not a safe drug. Aspirin actually has a very high incidence of both GI and cerebral hemorrhages. In fact, there is a trial where they compared apixaban with aspirin, and they found that they both almost produce the same amount of cerebral hemorrhage. So please do not think of aspirin as a very safe drug. And I think in future aspirin is going to be used less and less often, and the newer drugs are going to replace aspirin.
This question is from Dr. Solam Patel. What is the safety of NOACs in pregnancy and lactation?
Role of pregnancy. You cannot use NOACs in pregnancy. There is no data at all. So as soon as you find any evidence that somebody is pregnant, then NOACs will have to stop. Just like warfarin, you don't use warfarin in early pregnancy. You all know the thing. You don't use warfarin in the beginning. You use warfarin in the second trimester, and then you then stop warfarin in the third trimester. So it's a complicated process, but you have to do it if it's required. But NOACs, there is no data, so you can't do it.
This is a question from Dr. Ashwin Shah. How can I transit from warfarin to NOAC? How that can be done?
If you want to shift from warfarin to NOACs, you measure the INR. If the INR is high, you wait for 24 hours, then you repeat the warfarin, the INR. The next day, once the INR comes to between 1.5 and 2, you simply start the NOACs. And if you want to shift from warfarin, from NOAC to warfarin for whatever reason, again, you just stop the NOACs, the effect wears off within 12 hours, and you start the dose of warfarin. So shifting from one to other is extremely simple.